let's move forward to our third lecture. So this will be given, and we will be joined by Professor Shahed Omar from South Africa. He had his postgraduate clinical training and teaching on critical care and undergraduate teaching in chemical pathology. He is a senior critical care physician for the COVID-19 ICU at Chris Hani Baragwanath Academic Hospital. He is an adjunct professor at the School of Clinical Medicine at Witwatersrand University. Let's all welcome Professor Shahed Omar on the top clinical results of HA230 on organophosphorus poisoning.
Hi, thank you for the kind introduction. Well, thank you for staying for the last shift. And thank you to Jeffron for bringing us here. It was fantastic to listen to the last two speakers. I mean, these are things that you don't see every day, and the experience is great. What I want to do is, I know this whole day has been sepsis and liver and so on, and I want to look at toxicology, because it's really the low-hanging fruit and really not so complicated. I want to share our journey with the problem of organophosphate poisoning over the last few years. So we've been late to the scene, I must tell you, so there's been a lot of lessons for us to learn from the literature, and I'm just going to go through the issues. So essentially, organophosphate pesticides are widely used, and more recently, estimates are, better estimates are actually out there in the literature, and you can see that almost 20 million lives have been lost to not accidental, but intentional pesticide suicide. So from our side, in South Africa, in Johannesburg specifically, we noticed a more complicated cause. Now, we actually didn't have this problem for many years because the pesticide that we were dealing with were carbamates. And so everybody came in, they got managed with some atropine and maybe have been intubated, and 2 days later they were out back home and everything was hunky-dory. But a few years ago, we noticed that things were actually a little more complicated. And what is interesting is that there was a paradoxical effect in South Africa by removing carbamates off the supermarket shelves. Because what happened is these got rapidly replaced by unlabeled organophosphates, and these were true organophosphates. We actually had some of them measured, and we found that we were dealing in one instance with turbiphos. But there probably are many others too. So we did this retrospective review of 2 different time periods before and after the product was removed off the carbamates were removed off the supermarket shelves. And certainly we saw that in fact the length of stay and the complication rates and obviously the cost had dramatically gone up. And while we were seeing only, you can see, 9 cases in 2012, this rapidly went up. And in fact, this year we're probably going to be seeing close to 100 cases in our ICU. And remember, these are now true organophosphates, so they have a much more complicated cause. So we looked to see what we could do about this problem and try and improve the outcomes. Now, one thing, the outcomes were getting worse, but these patients end up staying a long time in the ICU, and they actually take up what we consider precious beds, and we want a high turnover in our setting. And so we looked at this review, and we thought, okay, would extracorporeal therapy be of benefit? And we didn't realize that a lot was happening in the world at the time. And based on the characteristics, we realized that it certainly was possible. And you can see that hemoperfusion, or what we're now going to be calling hemoadsorption, was probably the way to go based on the physical characteristics, the protein and lipid solubility. However, the volume of distribution was some concern, and we realized we're going to have to work around that. The type of adsorbent, we weren't familiar with the resins at the time, and there were issues with charcoal. And once we found out about the Jeffron cartridge, we thought this may be a good fit. And obviously, these were the modern resins. And then there are a whole lot of technical aspects that make them ideal, and we certainly have some data to show how well they've performed. So ultimately, we settled on the HA230. It had all the right characteristics. and we said, let's go and look at the literature and see how it's used. And I must tell you, this was a PubMed search, and I found 10 papers, and subsequent to that, there's been a meta-analysis. And I didn't realize that, in fact, all the non-observational trial data was sitting in Chinese, in the Chinese literature. There were about 11 papers. But this is what I found, and we thought, okay, let's learn from them, let's stay away from charcoal, and let's see, and let's use some of the strategies they've used here. But you can see that these are all observational or retrospective data. So in terms of the circuit, what did we have? We had a Prismaflex, and so we kind of had that special circuit set up. So we added the filter, we got rid of the post-dilution, we kept the pre-dilution because that's what other people in literature had done, and more for circuit patency rather than anything else. So we had to give a lot of heparin, like you've heard. You need lots of heparin, and we learned very quickly that don't try and skimp on the heparin. These are otherwise healthy patients. Their coagulation systems are generally good, so we loaded them with 20 units per kilo, and then a 15 unit per kilo infusion for the actual treatment cycle. So we had this combination of hemoabsorption and hemofiltration, and we took a duration. Now, you've heard from the talks today, we've got 2 to 6 hours, and we stuck with the 6 hours. That also came out of the literature. And really, it's because of the saturation due to cellular debris and other things. But essentially, the one issue that we hadn't been able to actually understand was the multi-compartment kinetics, because we didn't know how many cycles, how far apart that we actually needed this year, and we just stuck with the literature. The literature, you'll see, we actually decided, sorry, before I go to the literature, we actually decided we'll have a first cycle, we'll just make it simplify a 2-compartment model. We'll give one dose, we'll wait a certain period. We thought we'd wait at least a day, so 12 to 24 hours, and then we hopefully get some redistribution, and the second cycle, we see how we do. And we thought if this works, then later we can figure out what we've cleared. And sure enough, you can see that people had tried anything from 1, 2, up to 10 cycles, and really the effects seem to be consistent, although it's retrospective data. So we thought 2 cycles, we see if our money can take us there, and let's see how many people we can help. And then, after we completed the study and submitted for publication, etc., we then found this meta-analysis, and then we realized what we weren't aware of. And you can see there's 2 parallel searches in this one here, and if you do the PubMed, Medline, MBase search, you get nothing in terms of randomized trials. And if you do the Chinese search, you get 11 RCTs. So it was clear that we were quite behind at the back of the race. But essentially, there were limitations to this data, and the limitations, a lot of the studies just suggested randomization. They didn't actually tell you how. None of them actually had any concealment. And so the methodology was considered poor. And in fact, even though this suggests benefit across the board, length of stay, improvements in time to atropine usage, and outcomes, the recommendations can't be made from here, and they need further studies. So I'm happy that we've got at least the beginning of some data that strong data that you can start using. So what we did was for clinically suspected organophosphate and carbamate poisoning, we basically had this randomized trial. Now, it was an open randomized trial, and we didn't try and actually do a sham dialysis, which I know others have done. So that may be one of the shortcomings of our study, and there are others. But essentially, we went on. It was an adult group. We did standard care, and I must tell you, as part of our standard care, we don't do oxime therapy. It depends. The aging process is so variable. The time is so variable that they come in, and so we actually don't do this as part of our standard therapy. So essentially, we had supportive therapy and atropine or glycopyrrolate. We screened 64 patients. Now, as we started the study, the COVID pandemic hit us, so we lost a good few months during hard lockdown, And, but within a year, we had got our 40 patients after some exclusions, and we had all of them included in the primary outcome, which was length of ICU stay. So what we wanted to do, our outcome here, because we didn't have data, enough funding to do a huge outcome study, because the outcomes generally are mortality rate in ICU is less than 10%. Most of the people get there actually just occupy this bed for a very long time. They eventually get out. So our idea was just to see if we could actually get the stay to be shorter. So the primary outcome was to look at the hemoadsorption therapy and its effect on length of stay, and then secondary outcomes. We added a secondary outcome, a post-hoc outcome, because one of the things that one of the mistakes we made is we didn't consider the effect of intermediate syndrome. Now, when a patient with organophosphate comes in, poisoning comes into the ICU, you don't know whether they're going to develop this complication. And so there is a group that's actually going to get out quickly within the first week or so, and then there's a group that's going to stay in longer. And from our previous data, that sits around somewhere 45%. And fortunately, we had literally half of the patients actually with this prolonged stay. Now, there are other ways to define intermediate syndrome, but the problem with that is that the time is variable, and it could be mixed up with ICU weakness and what we call OPID, the organophosphate-induced delayed neuropathy. So we thought a time point was probably a better secondary outcome. So here you can just see the groups are very well matched. They're all young people, under 30, and you can see that they all of them had cholinesterase levels that were less than 10% of the lower reference limit. So now we didn't do red cell cholinesterase, but we just wanted to make sure this was severe. So serum cholinesterase were all low. You can see the average 200 or less. And we looked at platelet counts because we wanted to look at the effect of adsorption therapy on platelet counts. And there you can see, this is the overall 40 patients. They stayed an average of about 6.5 days in the whole group, or median 6.5 days. But you can see these 40 patients occupied 359 ICU days. So that's a lot of ICU days from our side that we thought or we hoped we could actually change or shorten. And you can see that when you have the whole group together, then the HA therapy is just a little bit shorter, but doesn't reach statistical significance, and neither do the other outcomes. But when we actually separate this into the length of stay more than 7 days, and that's the group that we're defining as a surrogate for intermediate syndrome, then you can see that, in fact, this group who are staying here more than 70 days occupy about 80% of those ICU bed days. So 77% actually, but the bulk of those 360 days or 359 days. And when you look then at the groups, you can see that the HA therapy is associated with a 7-day reduction per patient. So a median 7-day reduction. So from 17 days to 10 days. And that's what we found in observational data as well, something very similar. ICU antidotes days were also reduced from 13.5 to 8 days. And then finally, you can see that mechanical ventilation days were down to 6 days from 15 days. So these were all significant. Other secondary outcomes, you can see that the atropine dose was about a third, and you can see the other interesting thing on that graph is that the day 3 platelets they were slightly lower, 168 versus 198, but it didn't reach statistical significance. So that was a good thing. And then the other thing is that none of our patients had bleeding issues, and none needed transfusions. In terms of our complications, if you look on your left, I've got severe complications on the top, the rainbow colors, and they were death, organ dysfunction, cardiorespiratory arrest, status epilepticus, not just seizures, and then the blue ones are the non-severe complications. And you can see on the right, the top you've got in red the control group and absorption therapy at the bottom. And you can see that all those bad complications are all toward the control group, and in fact, the control group had 4 times more complications than the HA group. So there were definitely better clinical outcomes, and those complications refer to the entire population, not just to the ones that stayed greater than 7 days. And then, in terms of savings, so what we did was we looked at the cost in a South African, published in a South African setting, academic hospital, similar to ours, and we actually applied that cost to the number of extra days. And you can see the standard of care group, the cost there were about 2.5 million rand. I'll give you the euros in a little while. And then if you apply the cost of the intervention, now one of the things that you've got to do the intervention on everybody, you've got to perform the HA therapy on the entire group because you don't know who's going to stay longer or shorter. And so everybody gets the intervention. And you take that cost, there's a savings of about, just to make it universal or international, about 7,500 euros per patient. So from our perspective, that was fantastic. We were saving a bucket load of money. We were also gaining all these ICU days. So to conclude, the hemoabsorption therapy resulted in a cost saving, and that was driven by a reduction in the length of ICU stay for the patients staying longer than 7 days. And there was also a significant clinical benefit in terms of a combination of day 28 mortality, organ dysfunction, cardiac arrest, and re-intubation. Obviously, there are limitations. The primary outcome wasn't what we thought, so that's an important limitation that we got to just be aware of. It's a single-center study. There's so many different organophosphates, and they may behave differently, and so one has to just be aware of that. In terms of our future work, before I pen off, you can see that what we'd like to do is we'd like to actually look at the clearances of each cycle, and then also look at the redistribution concentration. So we hope that'll be our next study, to look at how much of the organophosphate we actually remove in each cycle, and then how it redistributes back between cycles, and that'll help us plan for future treatment sessions. Because we've heard previously, do you do 1 cycle, 2 cycles, 3 cycles, and we've had cases where we had to do 4 cycles. Now that we're doing this more frequently, we've done now probably close to 300 therapies. So we obviously we want to try and improve on this here. And with that, I want to thank you for your attention.
Thank you very much,